So I can barely be seen. Anyway, that's quite fine. So, as well as into the temporomandibular joint through the foramen of Fudo. Involvement of the skull base frequently implicates the facial nerve as it exits the mastoid toward the stylomastoid foramen. Spread inferomedially to involve the jugular foramen and carotid space may result in multiple cranial neuropathies, and spread to the sympathetic plexus may produce Horner syndrome. Infection may involve the mastoid bone as well as the middle cranial fossa, with complications including sigmoid sinus thrombosis, meningitis, empyema, and brain abscess. Contrast-enhanced CT and MRI play complementary roles in defining the extent of disease, with CT able to assess bony destruction and MRI evaluating soft tissue extension, bone marrow involvement, and intracranial spread. Nuclear medicine scans such as SPECT-CT and hybrid FDG PET MRI have also been shown to have clinical utility in assessing extent of disease. Malignant otitis externa. Contrast-enhanced axial CT images in soft tissue and bone windows show extensive soft tissue thickening of the external auditory canal with erosion of the adjacent mastoid. Axial T1 post-contrast MR image shows enhancing soft tissue along the external auditory canal and around the mastoid tip, with extension into the posterior temporomandibular joint and below the stylomastoid foramen. With erosion of the adjacent mastoid. Okay. Acute otomastoiditis and associated complications. Clinical otomastoiditis should be suspected clinically with post-auricular redness, tenderness, and edema. In this setting, imaging is crucial to evaluate for potential complications, including intracranial spread of infection. Contrast-enhanced CT of the temporal bones is the preferred imaging modality of choice because it can assess for destruction of the adjacent mastoid bony trabecle and overlying cortex, as well as soft tissue and dural venous sinus involvement. MRI brain with and or without IV contrast may be necessary in the setting of suspected intracranial complications such as meningitis, subdural empyema, and abscess formation. Coalescent mastoiditis. If allowed to progress, acute otomastoiditis may progress in the middle ear cavity and mastoid aerosols with destruction of the mastoid bony trabecle, which may extend to the inner and outer cortex of the mastoid by either enzymatic resorption or pressure erosion of inflamed mucosa. CT changes, again, if allowed to progress, acute otomastoiditis may progress in the middle ear cavity and mastoid air cells with destruction of the mastoid bony trabecle, which may extend to the inner and outer cortex of the mastoid by either enzymatic resorption or pressure erosion of inflamed mucosa. CT changes are usually easy to identify, but sometimes close inspection and comparison to the contralateral side is necessary to exclude subtle erosions. Subperiosteal abscess. Development of a subperiosteal abscess occurs secondary to spread of infection, either through vascular channels or an osseous defect in the outer costus of the mastoid. Typically, this occurs in the post-auricular region, and patients present with a palpable depressible abnormality behind the ear. Basal abscess, an abscess of the mastoid tip just medial to the insertion of the posterior belly of the digastric muscle. Because abscess formation here is deep to the sternocleidomastoid muscle, a clinical palpable abnormality may not be evident. Intracranial complications. Intracranial spread of disease is the most worrisome complication in the setting of complicated otomastoiditis. Defects of the mastoid inner cortex allow direct intracranial extension to the underlying dura, though infection may also spread throughout vascular channels. Defect of the mastoid inner cortex allow direct intracranial extension to the underlying dura, though infection may also spread through vascular channels. Complications include abscess formation and sigmoid sinus thrombosis. Meningitis may occur secondary to direct extension or infection, hematogenous dissemination, or retrograde thrombophlebitis. Meningitis. Complications include abscess formation and sigmoid sinus thrombosis. Meningitis may occur secondary to direct extension of infection, hematogenous dissemination, or retrograde thrombophlebitis, which is thought to be most common. An abscess is a fibrous line collection of pus, most commonly epidural in location in the posterior fossa, adjacent to the sigmoid plate. Imaging demonstrates a peripherally enhancing fluid collection with the central pus restricting diffusion on MRI. Subdural empyema is a more widespread process and appears as crescentic fluid collections along the convexities. Again, subdural empyema is a more widespread process and appears as crescentic fluid collections along the convexities. Falx a tentorium with adjacent dural enhancement, a central restricted diffusion. Again, subdural empyema is a more widespread process and appears as a crescentic fluid collections along the convexities, falx and tentorium with adjacent dural enhancement and central restricted diffusion. Although not an imaging diagnosis, meningitis can be seen as diffuse or localized leptomeningeal enhancement on post-contrast T1-weighted MRI sequences and sulcal flare hyperintensity. Dural sinus occlusive disease is a third complication of acute otomastoiditis. Dural sinus occlusive disease is a third complication of acute otomastoiditis and may be secondary to direct extension of retrograde thrombophlebitis and may be secondary to direct extension of retrograde thrombophlebitis and may be secondary to direct extension of retrograde thrombophlebitis. Mural sinus thrombosis occurs in the setting of paired sinus inflammation with the transverse and sigmoid sinuses most commonly affected because of proximity. Patients may present with headaches, sixth nerve palsy, mental status changes, and high fevers. Diagnosis throughout imaging remains exceptionally challenging. Therefore, clinical suspicions remains the most important diagnostic element. On contrast-enhanced CT, dual sinus rim enhancement without internal enhancement has classically been the imaging finding diagnostic of thrombosis, empty delta sign. However, reliability has been questioned. This was about dual sinus occlusive disease. Again, dual sinus occlusive disease is a third complication of acute otomastoiditis and may be secondary to direct extension or retrograde for thrombophlebitis. Dual sinus thrombosis occurs in the setting of perisinus inflammation with the transverse and sigmoid sinuses most commonly affected because of proximity. Patients may present with headache, sixth nerve palsy, mental status changes, and high fevers. Patients may present with headaches, sixth nerve palsy, mental status changes, and high fevers. Diagnosis throughout imaging remains exceptional, challenging. Therefore, clinical suspicions remain the most important diagnostic element. On contrast-enhanced CT, dual sinus rim enhancement without internal enhancement has classically been the imaging finding diagnostic of thrombosis, empty delta sign. However, reliability has been questioned. MRI offers improved diagnostic accuracy and utilizes both pre and post-contrast sequences. MRI offers improved diagnostic accuracy and utilizes both pre and post-contrast sequences. A foundation of MRI physics, MRI offers improved diagnostic accuracy and utilizes both pre and post-contrast sequences. A foundation of MRI physics is helpful. A foundation of MRI physics is helpful to determine the presence or absence of clot on various sequences and relies on how MRI sequences are required, as well as acuity of the thrombus. On traditional spin echo sequences, including T2 and T1 weighted sequences, acute thrombus is primarily composed of the oxyhemoglobin, which appears hypointense and can sometimes be differentiated for a normal flow void. Subacute thrombus methemoglobin. On traditional spin echo sequences, T2 and T1 weighted sequences, acute thrombus is primarily composed of the oxyhemoglobin, which appears hypointense and can sometimes be differentiated from a normal flow void. Subacute thrombus methemoglobin appears hyperintense in spin echo sequences and may sometimes be confused with slow flow throughout the sinus. Subacute thrombus methemoglobin appears hyperintense in spin echo sequences and may sometimes be confused with slow flow throughout the sinus. Subacute thrombus appears hyperintense in spin echo sequences and may sometimes be confused with slow flow through the sinus. Acute thrombus is primarily composed of dextran, which appears hyperintense and can sometimes be differentiated from normal flow void. I need some water. Note: On post-contrast T1 weighted images, thrombus does not always appear as a filling defect within the sinus. Of note, on post-contrast T1 weighted images, thrombus does not always appear as a filling defect within the sinus. Of note, on post-contrast T1 weighted images, thrombus does not always appear as a film defect within the sinus, as it was on contrast enhanced CT, given that over time, thrombus may converge to vascularized connective tissue. Therefore, fully contrast enhanced sinus does not always infer absence of thrombus. Normal anatomic variations may make diagnosis challenging. If the patients have differently sized transverse sigmoid sinuses with arterial flow mechanics, which may present as differences in signal intensity on MRI. Additionally, arachnoid granulations appear as well. Normal anatomic variations may make diagnosis challenging. Often patients have differently sized transverse and sigmoid sinuses with arterial flow mechanics, which may present as differences in signal intensity on MRI. Additionally, arachnoid granulations appear as well-defined round filling defects. On post-contrast imaging, these correspond in hyperintense signal on T2 weighted images and should not be confused with thrombus. Okay, so let's see some images. Complications of acute otomastoiditis. Axial CT images of the right temporal bone in bone in soft tissue. Indication of acute otomastoiditis. Windows demonstrate coalescent mastoiditis with loss of the mastoid septations, solid arrows, and outer mastoid cortex, dashed arrows, with an adjacent subperiosteal abscess. Solid arrow in image B. Subperiosteal abscess. Axial CT images of the right temporal bone in bone and soft tissue windows demonstrate coalescent mastoiditis with loss of mastoid septations, solid arrow, and outer mastoid cortex, just arrow, with an adjacent subperiosteal abscess. Solid arrow in image B. Axial CT image of the left temporal bone. Axial CT image of the left temporal bone. C. Axial CT image of the left temporal bone. C. In a different patient with acute otomastoiditis demonstrate opacification of the left middle ear. Again, axial CT image of the left temporal bone. Axial CT image of the left temporal bone. Axial CT image of the left temporal bone in a different patient with acute otomastoiditis demonstrate opacification of the left middle ear cavity and mastoid air cells, with dural venous thrombosis of the left sigmoid sinus, seen as a filling defect, dashed arrow, on MR venogram maximum image projection image. Let's see what is MIP image. MIP or maximum intensity projection in medical imaging, a technique primarily used in CT and MRI to visualize structures that have higher signal intensity than surrounding tissues, say blood vessel, contrast enhanced area. Using academic, measuring by projection the voxel with the highest intensity along each line of sight on the 2D image. Essentially, it compresses a 3D volume into a 2D image while emphasizing the brightness structure. This is particularly useful for angiography, where contrast is in vessels is much brighter than surrounding tissue. Steps in creating M by B. Acquire volumetric data sets, define the volume interest, the situation you want to visualize for each pixel in the output 2D image. Traverse throughout the corresponding voxel along the line of sight. Select the voxel with maximum intensity. Assign that intensity to the 2D image pixel. Highlight high intensity structure like arteries or contrast injection. Non-invasive way to visualize vessels. Some lesions can be rotated. Overlapping structure can obscure low intensity cities, cannot assess depth or internal structure where everything is projection on the plane, sensitivity to noise. Since noise high, since noisy high intensity voxels are dominant, CT angiography visualize artery enemies and angiography pulmonary invasive detection, bone classification highlighting. MIP maximal intensity projection. Let's see this in CT. Volume rendering, maximum intensity projection, average intensity projection. Okay, so now I can see that it's much more dense or bright, and it just shut down everything around it. It makes it looks, let's see, does MIP imaging makes the image look like 3D? Let's see the answer. MIP imaging does not produce a 3D image, but rather a 2D image that can give a sense of three-dimensional. It's a visualization method that takes a volumetric dataset such as CT or MRI and collapses into a 2D projection. I don't know what to say. Maybe it is, maybe it's not. I have no idea what to say. I don't know. It's interesting. It's very nice. Johnston. Let's see. And different patient with acute osteomyelitis demonstrate specification of the left middle ear cavity and mastoid air cells. Dura venous thrombosis of the left sigmoid sinus, seen as a filling defect on the MR venogram MIP image. Facial nerve involvement. Involvement of the facial nerve may occur secondary to direct involvement of the facial nerve may occur secondary to direct extension with dehiscence of the facial nerve canal. Involvement of the facial nerve may occur secondary to direct extension with dehiscence of the facial nerve canal. Bone erosion of the tympanic segment, however, may be indistinguishable for congenital demineralization dehiscence of the canal. Asymmetric enhancement of the nerve and punctus at T1 weighted MRI sequence indicate involvement. Labyrinthitis. Labyrinthitis. Sensory neural hearing loss and vertigo may occur secondary labyrinthitis. Sensory neural hearing loss and vertigo may occur secondary to extension of infection to the labyrinth. Spread of disease is often through the round or over windows. See section E on sensory neural hearing loss for imaging findings of labyrinthitis. Petrus apicitis. Pneumatization of the petrous apex occur in approximately 30% of the population with ulcers in continuity with the middle ear cavity and mastoid ulcers. Let's define pneumatization. Let's just take this one. Let's do something else. Let's take this one and here it is and ask him what is the meaning of pneumatization. Petrosapicitic mechanism in development of air-filled cavities within a bone. So understand pneumatization is development of air-filled cavities within a bone. Let's continue. Pneumatization of the petrous apex occurs in approximately 30% of the population with air cells in continuity with the middle ear cavity and mastoid air cells. Asymmetric pneumatization is common with fatty marrow within the pneumatization of the petrous apex occurs in approximately 30% of the population with air cells in continuity with the middle ear cavity and mastoid air cells. Asymmetric pneumatization is common with fatty marrow within the non-pneumatization petrous apex. Asymmetric pneumatization is common with fatty marrow within the non-pneumatized petrous apex. Additionally, trapped fluid within the petrous air cells is a common incidental finding and should not be mistaken for significant disease. The etiology of petrous apicitis is considered analogous to coalescence mastoiditis. The etiology of petrous apicitis is considered analogous to Sordans and asymmetrical disease in common with fatty marrow within the non-pneumatized petrous apex. Additionally, trapped fluid within the petrous air cells is a common incidental finding and should not be mistaken for significant disease. The etiology of petrous apicitis is considered analogous to coalescence mastoiditis. What is the meaning of this? What is it? Coalescence, mastoiditis, mastoiditis. Coalescence mastoiditis is a severe form of mastoiditis, an infection of the mastoid air cells called. The image stated the etiology of petrous mastoiditis and route to coalescence mastoiditis, which result in mastoid and Malvanti. Okay, so let's see what he means. Coalescence is severe form of movement in which the bony septa, the thin walls between the ulcers in the mastoid portion of the temporal bone, become destroyed due to infection. It is considered an application of acute otitis media. Mastoid ulcers normally have thin bony partitions. In acute mastoiditis, infection causes inflammation, post-inflammation, increased pressure in the cells. In coalescent mastoiditis, the infection is so aggressive that it erodes the bony septa, causing multiple ulcers to merge into larger cavities filled with pus. Gotcha. The etiology of petrous apicitis is considered analogous to coalescence mastoiditis with the resultant osteitis and destruction of the Bowling trabecle. What's the meaning of osteitis? So osteitis, inflammation of the bone. More specifically, it can refer to one of the following conditions: osteomyelitis, infection osteitis, many bacterial osteitis, alveolar osteitis, or dry pocket. This with coalescent osteoiditis, fulminant intracranial complication may occur throughout disruption of the anterior posterior cortex, including abscess, PMA. Okay. As with coalescent mastoiditis, fulminant intracranial complications may occur. As with coalescent mastoiditis, fulminant intracranial complications may occur through disruption of the anterior posterior cortex. Wait. Steroids, sprays, nasal sprays. Yes, can help alleviate same size. Yes, can have other symptom of the effect depends on the cause of the same size. Steroid decreasing cause of ingestion. The chemotherapy say they don't package of chemotherapy. Safety, size, safe. This information projections from the same size, especially chronic already caused, but they not return infection directly in acute bacterial stem cells. They are often used in combination with oral therapies and indication are directly indicated. And with coalescent mastoiditis, fulminant intracranial complications may occur throughout disruption of the anterior posterior cortex, including abscess and PM meningitis. As with coalescent mastoiditis, fulminant intracranial complications may occur. Through disruption of the anterior or posterior cortex, including abscess, empyema, meningitis, and dural venous sinus thrombosis. CT best demonstrate the lytic osseous changes of the petrous apex erythus. However, MRI with and without IV contrast is necessary to evaluate for the presence of intracranial complications. Characteristically, there is pathologic enhancement along the periphery of the petrous apex defect, presumably within the meninges, with enhancement possibly extending to Meckel's cave and or cavernous sinus. Now, I think the Meckel's cave is where the trigeminal nerve transverse. Let's see, Meckel's cave, also known as trigeminal cave. Let's Meckel's cave. Will make a cavity in the cerebrospinal fluid containing dural pouch in the middle. Meckel cave. Also known as trigeminal cavity, the cerebrospinal fluid space within the dural layer of the core is located in the middle cranial fossa near the petrous apex of the temporal bone. Petrous apex of the temporal bone. The structure houses the trigeminal ganglion and 3 division of the trigeminal nerve. Venous sinus. Classically, Gardenigo's triad, otitis media, 6 nerve palsy, and facial pain in the distribution of the 5th cranial nerve. This is the Gradenigo's triad, otitis media, 6 nerve palsy, and facial pain in the distribution of the 5th cranial nerve. has been described in patients with complicated petrosapasitis. However, the full triad is rarely present. Otitis media, fixed nerve palsy, and facial pain in the distribution of the fifth cranial nerve. Petrosapasitis, axial post-contrast T1 weighted image demonstrate a peripherally enhancing collection in the left petrous apex with associated bony erosion on the axial CT image of the left temporal bone. Chronic automastoiditis and complications. Chronic automastoiditis almost always results from long-standing Eustachian tube dysfunction. Chronic automastoiditis almost always result from long-standing Eustachian tube dysfunction and decreased intratympanic pressure. Wait. Chronic osteomatoiditis almost always results from long-standing Eustachian tube dysfunction and decreased intratympanic pressure, with most complication arising secondary to this altered physiology mechanism. Chronic osteomastoiditis and complications. Chronic osteomastoiditis almost always results from long-standing Eustachian tube dysfunction and decreased intratympanic pressure, with most complications arising secondary to these altered physiological mechanisms. Chronic osteomastoiditis almost always results from long-standing Eustachian tube dysfunction and decreased intratympanic pressure, with most complications arising secondary to these altered physiology mechanisms. Needle ear effusion. Chronic automastoiditis and complications. Chronic automastoiditis almost always result from long-standing Eustachian tube dysfunction. Okay, chronic automastoiditis and complications. Chronic automastoiditis almost always results from long-standing Eustachian tube dysfunction and decreased intratympanic pressure, with most complications arising secondary to death and third physiological mechanisms. Middle ear effusion. Middle ear effusion. Middle ear effusions are commonly seen in both acute and chronic automastoiditis and are visualized as layering simple fluid in CT and MRI. Acute and chronic automastoiditis and are visualized as layering simple fluid on CT and MRI. There is a little problem right now. There is a little problem right over here. There is a little problem. There is a little problem. There is a little problem. Okay. Middle ear effusion. Middle ear effusions are commonly seen in both acute and chronic automastoiditis and are visualized as layering simple fluid on CT and MRI. There is a little problem. 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 Granulation tissue. Granulation tissue frequently develops within the middle ear cavity with or without the presence of additional conditions such as effusion. Granulation tissue. Granulation tissue frequently develops Granulation tissue frequently develops within the middle ear cavity with or without the presence of additional conditions such as effusion. Wait a second, there is a problem, 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 there is a problem. Wait a sec, I need to prescribe augmentin. I need to prescribe an augmentin. Come on, come on. There is a problem, there is a problem. I need to prescribe augmentin, I need to prescribe augmentin. I need to prescribe augmentin, I need to prescribe augmentin. I need to prescribe augmentin, I need to prescribe augmentin. Where is it? Here it is. Augmentin, בבקשה. Really is 875 milligrams 2 times per day for 7 days. This is it. Indication sinusitis that is with pus and more than 10 days. נקבע הוציא אנטיביוטיקה אוגמנטין. יש כאן אינדיקציה. חוסר שיפור מעל 10 ימים עם כאבי סינוסים ונזלת נבלתית אינם בלי חום ובלי סיבוכי סינוסיטיס מרכזיים ומגענה בראייה ספונטנות עיניים עדיין מצדיקים אנטיביוטיקה ורגישות לפניצילין. Okay, so let's מלאכת המחשב, רשמתי לך ארגומנטין. Should Frank well Bischof in spray schwer Schwer Starch Weggetwalen should Fordish Gewissen Realität in kurz. Okay, so we did it. We finished, I think, the problem maybe partially. So I can close it. Maybe I'll close in some minutes because we work on it. Now I also need some water here. Okay, let's continue. Much more importantly, let's continue. Granulation tissue. Granulation tissue frequently develops within the middle ear cavity with or without the presence of additional conditions such as effusion. As compared to cholesteatoma, granulation tissue usually has no mass effect and encases the middle ear structures rather than displacing or destroying them. Because granulation tissue is vascularized, it will enhance avidly on post-contrast T1 weighted MRI sequences. Granulation tissue is much more common than cholesteatoma or cholesterol granulomas. Because granulation tissue is vascularized, it will enhance avidly on contrast T1 weighted imaging and MRI sequences. T1 weighted MRI sequences. Granulation tissue is much more common than cholesteatoma and cholesterol granulomas. Cholesterol granuloma and mimics. But what causes the administration? Granulation tissue forming within the middle ear cavity with or without presence of additional conditions such as effusion. Granulation tissue frequently and granulation tissue. Let's see. What are the causes? What are the causes of granulation tissue in the middle ear cavity? And what is the most common cause? Right? This is my question to you. Granulation tissue in the middle cavity is a reactive tissue composed of new capillaries, fibroblasts, and inflammation cells that typically forms in response to chronic irritation and inflammation. Its present usually indicates an ongoing pathological process. The causes can be broadly categorized as follows: chronic otitis media, most common cause of granulation tissue in the middle ear, usually associated with chronic suppurative otitis media, particularly with perforated tympanic membrane. Persistent infection leading to inflammatory exudate, which triggers granulation formation, may be localized in the tympanic cavity, attic epidiconal mastoid. Most common cause of granulation tissue in the middle ear, chronic otitis media, usually associated with chronic suppurative otitis media, particularly with perforated tympanic membrane. Persistent infection leading to inflammation and exudate, which triggers granulation formation, may be localized in the tympanic cavity, attic epitympanum, or mastoid. Secondary granulation tissue can form around cholesteatoma due to chronic inflammation and bone erosion, often presents with full-smelling otorrhea, and may cause ossicular destruction. Granulation tissue may obscure the cholesteatoma during otoscopic examination. Hyperliminal perforation, especially marginal perforation, which allow persistent entry of bacterial inflammation mediators into the middle ear. Granulation tissue may form at the edge of the perforation as part of healing or reactive process. For surgical dysmedia, neoplastic or rare causes, like vascular lesion, can induce reactive granulation tissue, granuloma, granulomatous disease, irregular tuberculosis, are rare causes. Otitis media with effusion or current otitis media less commonly causes significant granulation tissue. Chronic effusions may lead to mild mucosal proliferation, but usually not extensive granulation tissue. Post-surgical or traumatic causes after tympanostomy, tube placement, or ear surgery, granulation tissue can form at the incision site or tube site, usually resolve with local care or cauterization. Neoplastic or rare causes. Medial ear tumors, glomerulus tumors, vascular lesions can induce reactive granulation tissue. Granulomatous diseases, Wegener, tuberculosis, are rare causes. Got you, sir. Aye, aye, sir. Under your command. So, cholesterol granuloma and mimics. Cholesterol granuloma within the middle ear cavity occurs much less frequent than other complication. Again, cholesterol granuloma and mimics. Cholesterol granuloma within the middle ear cavity occurs much less frequently than other complications. Cholesterol granuloma develops secondary to eustachian tube dysfunction and negative pressure of the middle ear. This results in mucosal edema and vascular proliferation with rupture. Again, cholesterol granuloma within the middle ear cavity occurs much less frequently than other complications. Cholesterol granuloma develops secondary to eustachian tube dysfunction and negative pressure of the middle ear. Cholesterol granuloma? What? Cholesterol granuloma is related to cholesterol? Yes, the cholesterol granuloma is indeed related to cholesterol, but it's not just simple cholesterol deposition, it's a reaction to breakdown of products of blood and cholesterol crystals. Let me explain in detail. Cholesterol granulomas usually form in areas like the middle ear mastoid air cells or petrous apex. They are thought to arise when there is impaired ventilation and drainage of air-containing spaces leading to blood accumulation. Cholesterol involvement. The trapped blood breaks down, releasing cholesterol crystals from the cell membrane of erythrocytes and other cells. What? Cholesterol granuloma usually form in areas like middle ear mastoids and petrous apex. They are thought to arise when there is impaired ventilation and drainage of air-containing spaces, leading to blood accumulation. Cholesterol involvement. The trapped blood breaks down, releasing cholesterol crystals from the cell membranes of erythrocytes and other cells. Inflammatory response. These cholesterol crystals are foreign to the body, triggering a glomerulomatous inflammatory response characterized by multinucleated giant cells, macrophages, chronic inflammatory cells. Essentially, the body walls of the cholesterol crystal forming the granuloma. Appearance on imaging. Cholesterol granulomas are often high T1 and T2 weighted MRI due to the cholesterol and blood products. The lesion is not caused by systemic hypercholesterolemia. It's local cholesterol deposition from breakdown of blood products, not circulating cholesterol. If you want, wide petrous apex is particular. Oh, yes. Here is why the petrous apex is particularly prone to cholesterol granuloma. The petrous apex is part of the temporal bone that contains air cells in some individuals. Pneumatized petrous apex. These air cells communicate poorly with the middle ear in many cases, so ventilation is limited. Poor ventilation cause negative pressure inside the air cells. Negative pressure, transudation of blood or fluid from the nearby vessels. Blood stagnant breakdown of erythrocyte cholesterol crystal released. Body reacts with chronic inflammation, forming cholesterol granulomas. Specifically, it is a dead-end space with limited drainage. Surrounding bone is dense, so resorption of blood product is slow, allowing cholesterol crystal to accumulate. In contrast, a better ventilated area like the main middle ear cavity usually clear blood more efficiently, so granulomas are less common. Clinical implication: this lesion can expand slowly and cause bone erosion, hearing loss, vertigo, or cranial neuropathies, depending on the size and location. Is prone because it's poorly ventilated. Relatively isolated air cell system where trapped blood can break down into cholesterol crystals, triggering granulomatous inflammation. And what is the treatment for this? The treatment for cholesterol granuloma depends on the symptom location and size, observation, indication. Small asymptomatic lesions discovered incidentally. Cholesterol granuloma are benign, slow growing. So if they aren't causing problems, you can monitor with periodic imaging, usually MRI. Surgical intervention, indication symptomatic lesion or those causing bone erosion, hearing loss, vertigo, or cranial neuropathy. Drain the cyst, remove contents, restore ventilation and aeration of the affected air cells, prevent recurrence. Common approaches. Transmastoid or middle fossa approach for petrous apex lesions. Marsupialization. Create a permanent drainage pathway into the middle ear or mastoid to prevent reaccumulation. Cyst removal. Main approach for petrous lesion. Sometimes the cyst wall is partially excised. Complete excision is often difficult due to proximity to neurovascular structures. Recurrence can occur if ventilation is not restored because blood may reaccumulate. Marsupialization or drainage is usually more effective at preventing recurrence than simple excision. There is no medical therapy that dissolves cholesterol granulomas. Antibiotic and steroids or steroids are not effective unless there is a secondary infection. Asymptomatic, just observe symptomatic surgical drainage, marsupialization. Key principle: restore ventilation to prevent recurrence. And if you restore ventilation without removing the cholesterol, can it cure by that only? In some cases, restoring ventilation alone can be sufficient to cure or stabilize the cholesterol anyway. Another problem: restoring ventilation result over time the canal may shrink or even resolve because no new cholesterol vessels are deposited and the existing ones are slowly cleared by macrophages. Great. So the, this this works better for small granulomas. Large systemic granulomas may not fully resolve and can continue to cause mass effect. In this case, drain or partial removal is usually a still recommended. Follow-up is essential. Okay, so let's go and take some water. Cholesterol granuloma in mimics. Cholesterol granuloma within the middle ear cavity occurs much less frequently than other complications. Cholesterol granuloma develops secondary to eustachian tube dysfunction and negative pressure of the middle ear. Cholesterol granuloma mimics cholesterol granuloma within the middle ear cavity occurs much less frequently than other complications. Cholesterol granuloma develops secondary to stagnated dysfunction and negative pressure of the middle ear. This results in mucosal edema and vascular proliferation with rupture. The breakdown varies within tissue release cholesterol, which incites a foreign body giant cell reaction leading to formation of cholesterol granuloma. So you understand the idea of cholesterol granuloma is that the negative pressure causes erythrocyte to come from blood vessels to the cavity that is negatively pressured to the erythrocytes that came out of the vessels, break down and release cholesterol. The body attack or identifying this cholesterol as foreign body and cause a granulation tissue. And this is the cholesterol granuloma. This is the idea of the cholesterol granuloma. This is why negative pressure causes cholesterol granuloma. All the idea is this: negative pressure, erythrocyte coming out of blood vessels, just sucking me out because of the negative pressure. Those erythrocyte release, break down, and release cholesterol. The body identify those cholesterols and as foreign bodies. The reaction is leading to formation of granuloma. I mean cholesterol granuloma because this is the reaction to cholesterol from erythrocyte. This is the idea of cholesterol granuloma. So you need an unventilated area or problem with ventilation to cause this negative pressure. This is why the same cause for cholesterol granuloma is the negative pressure that can happen in, for example, the middle ear, the petrous apex that's pneumatized, and things like this. So here are some images of a cholesterol granuloma. We start with CRCT images in soft tissue, which is A, and bone. You see this erosion of bone. You see this hypodense lesion, it seems, demonstrate a well-defined expansolytic lesion of low attenuation in the right petrous apex. Axial T2, axial T1 and T2. Okay, this is T1, this is T2. MR images demonstrate intrinsic T1 hyperintense signal within the lesion, secondary to methemoglobin with the T2 hypointense rim from hemosiderin deposition. So you understand that, oh, wait, with T2 hypointense rim from hemosiderin deposition. Okay, great. So let's continue. Lesion can arise in the middle ear cavity or the petrous apex. We're talking about cholesterol granuloma. In the middle ear, patients will present with the blue tympanic membrane, hemotympanum, and plus or minus conductive hearing loss. When confined to the middle ear cavity, these lesions rarely result in erosive or destructive change. Cholesterol granuloma of the petrous apex, however, tends to be erosive and expansile, potentially involving the carotid canal anteriorly or cerebral pointine angle posteriorly. If with petrous apesitis, patients require an aerated petrous apex to develop petrous apex cholesterol granuloma. Although not a common lesion overall, cholesterol granuloma within the petrous apex is 10 times more common than cholesteatoma and 40 times more common than mucocell. On CT, lesions appear as a well-defined expansolytic lesion. MRI demonstrates characteristic findings of T1 hyperintensity, secondary to methemoglobin, and heterogeneity on T2 weighted imaging, secondary to hemoglobin breakdown products. A T2 hypointensity may be present, though to reflect hemosiderin. Lesions notably do not enhance. Additional complications. Additional complications include acquired cholesteatoma as well as vesicular erosions, which are discussed further in the section on conductive hearing loss. Additional complications. Additional complications include acquired cholesteatoma as well as vesicular erosions, which are discussed further in the section of conductive hearing loss. Wait, so cholesterol granuloma can complicate. Wait, no, not cholesteatoma. Wait a sec. Yes, cholesteatoma may be a complication of cholesterol granuloma. Not exactly. Cholesteatoma and cholesterol are distinct entities, but they can sometimes coexist or influence each other. Let's just see for a second what is going on over here. And we don't see so many cool blah blah blah. Sure, if it's not coming to you guys. Blah. Okay. Conductive hearing loss. High resolution CT is the modality of choice for evaluating the etiology of conductive hearing loss. High resolution CT is the modality of choice for evaluating the etiology of conductive hearing loss, given its superior spatial resolution as well as improved visualization of the bony structures. Again, high resolution CT is the modality of choice for evaluating the etiology of conductive hearing loss, given its superior spatial resolution as well as improved visualization of the bony structure. CT of the temporal bone is usually performed without contrast administration. However, in the setting of acute infection, contrast may provide additional benefit in evaluation of subperiosteal abscess form. Again, however, in the setting of acute infection, contrast may provide. Oh, so he said that I don't need temporal bone usually performed without contrast administration. However, in the setting of acute infection, contrast may provide additional benefit in evaluation of subperiosteal abscess formation or intracranial spread of infection. Pathology resulting in conductive hearing loss may arise from either the external auditory canal or the middle ear. Again, in the setting of acute infection, contrast may provide additional benefit in evaluation of subperiosteal abscess formation or intracranial spread of infection. Pathology resulting in conductive hearing loss may arise from either the external auditory canal or middle ear. Again, pathology resulting in conductive hearing loss may arise from either the external auditory canal or the middle ear. Okay. Okay. So, external auditory canal exostosis. Exostosis are benign bony protrusions of the osseous external auditory canal, thought to be secondary to repetitive cold water exposure. As such, lesions are often bilateral, with patients presenting with conductive hearing loss and frequent episodes of disease external. On CT, these lesions appear as broad-based bony protrusions, often arising from the tympanomastoid and tympanosquamous sutures, resulting in narrowing of the external auditory canal. So let's see exostosis on CT. on the ear. External auditory canal exostosis. Okay, so we are on. And what do we see over here? Here it is. It's like bony protrusion to the external auditory canal. You can see it on coronal again, bony protrusion to the external auditory canal. Those are the exostosis. So exostosis are benign bony protrusions of the osseous external auditory canal, thought to be secondary to repetitive cold water exposure. As such, lesions are often bilateral, with patient presenting with conductive hearing loss and frequent episode of the external. On CT, these lesions appear as broad-based bony protuberance, often arising from the tympanomastoid and tympanosquamous sutures, resulting in narrowing of the external auditory canal. Osteoma. Osteomas occur less frequently than exostosis and are often unilateral. Focal bony outgrowths occurring in the most superficial portion of the osseo-sternal auditory canal. As with exostosis, these lesions occur more frequently in patients with repetitive cold water exposure. External canal cholesteatoma. External auditory canal cholesteatoma is a rare lesion typically presenting in patients in their 40s to 70s. Incidence is approximately 0.1 to 0.5%, with most cases occurring spontaneously. However, cholesteatomas can develop secondary to prior trauma, surgery, or radiation. Disruption of the normal self-cleansing mechanism of the lateral migration of keratin debris from the tympanic membrane leads to cyst formation within the wall of the external auditory canal with associated periostitis, bone erosion, and fragmentation. External auditory canal cholesteatoma frequently involves the posterior and inferior walls of the canal, with patients presenting with chronic otalgia, pruritus, and otorrhea. So let's see. Exostosis and osteoma, axial and coronal. We see protrusion of the bone. CT images of the right temporal bone. CT images, let's see. Okay. CT images of the right temporal bone demonstrate sessile broad-based bony protuberance arrow in the bony external auditory canal, compatible with exostosis markedly narrowing in the lumen. Axial and coronal CT images of the left temporal bone in a different patient with external auditory canal osteoma demonstrate focal bony outgrowth arrows arising from the superficial bony external auditory canal. CT is the gold standard for evaluation and reveals a soft tissue mass. We're talking about external auditory canal cholesteatoma, yeah? So CT is the gold standard for evaluation and reveals the soft tissue mass in the external auditory canal with underlying bony erosion and sequestrated bony fragments. Distinguishing external auditory canal cholesteatoma from underlying squamous cell or basal cell carcinoma is often not possible throughout CT imaging alone. MRI will demonstrate a diffusion restriction lesion secondary to accumulated keratin debris. So we can understand that cholesteatoma causes restricted diffusion. Keratosis obturans. Keratosis obturans is a disease of young to middle-aged adults and is the result of an abnormal accumulation of keratin, resulting in a thick plug within the external auditory canal and subsequent conductive hearing loss. Keratosis obturans. It's just another name for it's a rare impaction, a rare condition where a plug of dead skin accumulates in the bony part of the external ear canal, causing pain and hearing loss. which is another name also function. Now we can implement no, there is not just another name for some function, though the two conditions are often confused with one another. For both involve block of the canal, there are fundamentally different disease with distinct composition, symptoms, and potential complications. Keratosis obliterans is a rare and most severe condition that requires specialist medical attention for proper treatment. A hard, dense plug of accumulated keratin and some earwax. The plug is a layered on skin appearance of the level of cerumen. The occasion the forms accumulation in the deeper bony portion of the canal. The complication typically occurring in the outer abdomen. Requires meticulous, gentle removal, often with sterile tools and potentially under general anesthesia due to severe pain. Occurrence in common, specific in long-term follow-up, typically treated with softening, interrupts, manual removal, or radiation. Frequently in younger patients, it has been associated with conditions such as bronchiectasis and sinusitis. Can occur in age group, but it's more common in the elderly people who use hearing aids and those with narrow ear canals. Very painful in the throat, I must say. So let's continue. Okay, so keratosis occurrence is a disease of young to middle-aged adults and is a result of abnormal accumulation of keratin, resulting in thick plug within the external auditory canal and subsequent conductive hearing loss. Got it? Of course you got it. What else can I say? Let's continue. Let's move on. Okay. Temporal bone CT is the imaging modality of choice and demonstrates a soft tissue mass within the external auditory canal, often smoothly expanding the canal. While cerumen may have a similar appearance on CT, it does not expand the external auditory canal. Okay, so we see some soft tissue that expands the external auditory canal. It looks very like soft tissue with some hyperattenuation inside it. I don't know. Oh, this is cholesteatoma, so it probably causes bone erosions. External auditory canal cholesteatoma, coronal and axial CT images of the right temporal bone demonstrate a soft tissue mass in the external auditory canal with bone erosion and central bone fragments. Keratosis obturans, axial CT images of the left temporal bone in soft tissue and bone erosion, central bone fragments. Show complete soft tissue opacification of the left external auditory canal with mild smooth expansion of the canal. Show complete soft tissue opacification of the left external auditory canal with mild smooth. Middle ear cholesteatoma. Cholesteatoma is an expanding accumulation of discolored keratin epithelium and may be either congenital or acquired. The majority of cholesteatoma are acquired and are further divided into primary acquired, which account for 20% of all middle ear cholesteatomas and develop behind an intact pars flaccida in patients without a history of otitis media, and secondary acquired, which expand into the middle ear throughout a defect in the pars tensa. Congenital cholesteatoma originate from bionic epithelial rest and can develop anywhere in the temporal bone. Cholesteatoma acquired, the majority of cholesteatoma acquired. Okay. Cholesteatoma have characteristic location in which they develop with somewhat typical growth patterns. Regions of the pars flaccida begin in Prusak space with gradual medial displacement of the vesicular chain. These regions will also commonly extend posteriorly into the adductus and atrium and into the mastoid air cells. Occasionally, the retraction pocket may also involve the posterior superior portion of the tympanic membrane. Occasionally, the retraction pocket may also involve the posterior superior portion of the tympanic membrane, or pars tensa. Occasionally, the retraction pocket may also involve the posterior superior portion of the tympanic membrane. Okay. Occasionally, the retraction pocket may also involve the posterior superior portion of the tympanic membrane, or pars tensa. The posterior superior pars tensa? Pars tensa is not what? Pars tensa. Now, here we see the pars tensa. The pars tensa is not the superior part. It's not the superior portion. What are you talking about, you little man? What are you talking about? Occasionally, the retraction pocket may also involve the posterior superior portion of the tympanic membrane, or pars tensa, with cholesteatoma arising from the location initially involving the fascia recess and then expanding medially to involve the sinus tympani. As these lesions grow, they expand medial to the ossicular chain and displace the ossicles laterally, an important distinguishing feature from pars flaccida cholesteatoma, which displays the ossicles medially. Very interesting, very interesting. You say that the pars tensa cholesteatoma displays the ossicles laterally when to differentiate it from pars flaccida cholesteatomas, which displays the ossicles medially. CT has excellent spatial resolution and is the initial examination of choice. Where am I? CT has excellent spatial resolution and is the initial examination of choice. Imaging is important in order to determine extent, especially involvement of sites difficult to assess surgically, including the supratubal recess as well as the sinus tympanic. What are those spaces? Supratubal recess. They made it up. Can't be that there is such space. Supratubal recess. What are we talking about? There is such space. Supratubal. What are you talking about? He thinks they something. Where is the image? Where is the image? Okay. Supratuberosis. There is no supratuberosis. Supratuberosis, please. Oh, I have no idea what I'm looking at. Promontory, jugular bulb, hippotympanum, cochleariform process, stachytube orifice. Okay, it's just trying to say some things, I know. Supratuberosis as well as the sinus tympani. CT should be used to evaluate for erosion of the scutum. Ossicles, tegment tympani. Tegment tympani is not just the epitympanum. I don't understand what he says. Tegment tympani, yeah. That's a tegment tympani, just the border of the, of course, it's in the epitympanum, it's the roof of the epitympanum. If I say the tube, internal jugular vein. Internal jugular vein goes very closely to the inner ear, I must say. Internal acoustic meanings. This one I know. This one I know. Okay, so the tegment tympani, where it is, this is the tegment tympani. Tegment tympani is just the roof of the epitympano. Can I say, let's say that, just one, can I say that, can I, can I say that tegment tympani is the roof of the epitympano? And answer yes, you can accurately say that a tegment tympani is the thin plate of bone that forms the roof of the middle ear cavity, and more specifically, it forms the roof of the epitympanum attic, which is the upper portion of the epitympanum attic, upper part of the middle ear above the level of tympanic membrane. Tegment tympani forms the superior boundary of the epitympanum and separated from the cranial cavity, middle cranial fossa. Thank you very much. Wait, he said that attic is just another name for epitympanum? Question? Exactly. In otology terminology, the epitympanum is a formal anatomical term, and the attic is a more collaboration or surgical term. Very nicely. Tegment tympani, otic capsule, inner ear structures with the lateral semicircular canal almost otic capsule. CT should be used to evaluate for erosion of the scutum, ossicles, tegment tympani, otic capsule, inner ear structures with the lateral semicircular canal most commonly involved, facial nerve canal, carotid canal, and sigmoid plate. What is the sigmoid plate, for God's sake? Just makes up some, okay? Sigmoid signs, okay? No, I want to know where's the sigmoid plate in an ear mastoid air cells, bone over segment signs. Oh, here it is. Bone over segment signs. Sigmoid plate. Sigmoid plate. Here it is. I think that it is right over here. Let's do open image in new tab. This is the sigmoid plate. You might have sigmoid plate. Jugular bulb, sigmoid plate, middle cavity, carotid canal. Carotid canal is more anterior than the jugular bulb. Carotid canal, jugular bulb. You can see that right over here, of course. Okay, so this is very bad. The presence of soft tissue in the middle ear cavity and CT is non-specific. It may represent granulation tissue, secretions, cholesteatoma, cholesterol or neoplasm. MRI may be obtained for the assessment of intracranial involvement, as well as the presence of meningoencephaloid cell secondary to destruction of the tegment tympani. Cholesteatomas are T1 hypo and mildly T2 hyper intense without associated enhancement. MRI may be obtained for assessment of intracranial involvement as well as the presence of a meningoencephaloid cell. What is meningoencephaloid cell? Why he makes up terms? Meningoencephaloid cell, please. Meningoencephaloid cell is a type of neural tube defect in which both meninges and brain tissue herniate throughout a defect in the skull. It is essentially a protrusion of intracranial contents outside their normal compartment, usually covered by skin or a thin membrane. Here is a detailed breakdown. Okay. Meningoencephaloid secondary to destruction of the tegment tympani. MRI may be obtained for the assessment of intracranial involvement as well as the presence of meningoencephaloid cells secondary to destruction of the tegment tympani. Cholesteatomas are T1 hypo and mildly T2 hyper intense without associated enhancement. So cholesteatomas do not enhance, or still enhances with contrast. No, cholesteatoma does not enhance with contrast. Maybe is a more precise explanation. Okay, so but cholesterol, no cholesterol, and what about cholesterol, granule? They do not enhance cholesterol behave differently from cholesterol imaging because coronary vascularity is distinct. Cholesterol ask if it enhances. Well defined, intense, peripheral septal enhancement to the vascular capsule conversational systems usually do not enhance, they usually no restrict diffusion, unlike cholesterol. Enhancement often show peripheral enhancement where cholesterol do not, except for certain chemicals. T1 signal is typically hyperintense, cholesterol usually hyperintense T1. DWI cholesterol does not receive diffusion, cholesterol does. Cholesterol is non-enhancing, DWI positive, and T1 hypointense. Cholesterol granuloma is peripherally enhanced, often T1 hyperintense, and DWI negative. Okay, great. May represent granulation tissue secreting cholesteatoma, cholesterol granuloma, or neoplasm. MRI may be obtained to assess microRNA involvement, where the presence of minimal cell secondary to destruction of the tegment tympan. Cholesteatomas are T1 hypo and mildly T2 hyperintense without associated enhancement. Characteristically, lesions demonstrate reduced diffusivity, which is particularly helpful in the postoperative setting in distinguishing recurrent cholesteatoma from granulation tissue which does not receive diffusion. So cholesteatoma receive diffusion, namely they are DWI positive if you want. Okay? So lesions demonstrate reduced diffusivity, which is particularly helpful in the postoperative setting in distinguishing recurrent cholesteatoma from granulation tissue which does not restrict diffusion. The use of a non-echoplanar diffusion. Oh, it talked a lot. It talked a lot. מתמטיקה פיננסית, ידיעותיי במתמטיקה פיננסית הם מאוד נמוכים, איך אני אדע מה... איך יהיה לי מושג במתמטיקה פיננסית? מה אני אגיד על מתמטיקה פיננסית? לא מספיק מבין מתמטיקה פיננסית. לא למדתי. כמה לא מועיל התשובה הזאת. Cholesteatomas are T1 hypo and mildly T. We said that without associated enhancement. Characteristically, lesions demonstrate reduced diffusivity, which, אוקיי, אמרנו, cholesteatoma יש להם DWI חיובי, כלומר הם restricted diffusion ב-MRI, או למה אני מדבר בעברית? Cholesteatoma are positive on DWI, namely the restrict diffusion, namely restricted diffusion for the cholesteatoma, which will help you to differentiate them from granulation tissue, which are DWI negative, namely they do not restrict diffusion. Great. From granulation tissue, which does not restrict diffusion. The use of a non-echoplanar diffusion weighted imaging increases sensitivity for detection of even small lesions given its increased spatial resolution, thinner slice thickness, and reduced susceptibility artifacts. The use of non-echoplanar diffusion weighted imaging. What is non-echoplanar? Additionally, granulation tissue enhances, whereas cholesteatoma do not. We said that, right? We said that. Peripheral enhance and no. Congenital, no. What is it? Granulation tissue enhances, whereas cholesteatomas do not. Facial nerve paresis or paralysis occur in 1% of cholesteatomas and results from erosion of the facial nerve canal, most often the anterior tympanic segment. Congenital dehiscence of the facial nerve predisposes patients to paralysis. Congenital dehiscence of the facial nerve. What is dehiscence of the facial nerve? What is congenital deficiency of the facial nerve? Let's see. Let's do this. What what does it mean by congenital dehiscence of the facial? Congenital facial nerve refers to a development defect where there is a deficiency or absence of the bony covering of the facial nerve canal. This condition is present from birth, congenital, and allows the facial nerve to be exposed to the medial ear cavity. Predisposition to paralysis. The English say that the congenital dehiscence predisposition to paralysis. Located dehiscence most frequently occur along the mid-tympanic segment of the facial canal, excluding surgery. The exposed nerve is more susceptible to injury during surgery. Great. Let's continue that. Okay, so facial nerve paralysis or paralysis occur in 1% of cholesteatomas and result from erosion of the facial nerve canal, most often the anterior tympanic segment. Congenital dehiscence of the facial nerve predisposes patients to paralysis, with dehiscence most frequently occurring along the mid-tympanic segment. Additionally, congenital dehiscence predisposes the nerve to injury during surgery. Vesicular chain abnormalities. The ability of the vesicular chain is assessed by direct inspection with otoscopic pneumatic manipulation as well as various acoustic reflexes. Erosion, fixation, and discontinuity of the vesicle can result in conductive hearing loss and may be congenital or acquired. Okay, it's a pathology of the middle ear, vesicular chain abnormality. Ability of the vesicular chain is assessed by direct inspection with otoscopic pneumatic manipulation as well as various acoustic reflexes. Erosion, fixation, and discontinuity of the ossicles can result in conductive hearing loss and may be congenital or acquired. Erosion, fixation, and discontinuity, and I think that one of the most common wired things is discontinuity from trauma, ossicular chain discontinuity, or otosclerosis, which is fixation of the foot plate of the stapes to the promontory over window and everything. So those are two things that we can think about. Okay, so cholesteatoma, what we see right over here, axial and coronal CT images of the left temporal bone in a patient with no prior surgical history demonstrate a soft tissue ossification, the middle ear cavity, mastoid complex, and external auditory canal with extensive bony erosion, including the bony covering of the lateral semicircular canal, solid arrow, and roof of the external auditory canal, dashed arrow. The ossicles are absent from complete erosion. DWI-MR image demonstrate restricted diffusion of the lesion. Of course, this is a cholesteatoma, so it will cause restricted diffusion, so it will be bright on DWI, or if you want, hyper intense on DWI compared to the surrounding tissue. Congenital ossicular abnormalities. So, congenital ossicular malformations, again, congenital ossicular abnormalities. Congenital ossicular abnormalities. Congenital ossicular malformations are frequently unilateral and often have associated external ear abnormalities, with the diagnosis usually made in childhood. However, in the case of minimal external ear deformities, diagnosis may be delayed until adulthood. There is a wide array of potential abnormality that occur in various combinations. including complete or partial hypoplasia, total ossicular fusion, and ossicular fixation. In the second setting of hypoplasia, the long process of the incus and stapes are most commonly affected. In the setting of hypoplasia, the long process of the incus and stapes are most commonly affected. In the setting of hypoplasia, the long process of the incus and stapes. There is a long process to the stapes? No, it means the long process of the incus and the stapes are most commonly affected. Post-inflammatory ossicular fixation. Post-inflammatory ossicular fixation represents an abnormal fusion of the ossicles to the tympanic cavity. Again, post-inflammatory ossicular fixation. Post-inflammatory ossicular fixation. Post-inflammatory ossicular fixation represents an abnormal fusion of the ossicles to the tympanic cavity. Post-inflammatory ossicular fixation represents an abnormal fusion of the ossicles to the tympanic cavity. In the setting pure middle ear inflammatory disease, three subtypes have been described: fibrous tissue fixation, post-inflammatory ossicular fixation. Represents an abnormal fusion of the ossicles to the tympanic cavity. Again, post-inflammatory ossicular fixation represents an abnormal fusion of the ossicles to the tympanic cavity in the setting prior middle ear inflammatory disease. Three subtypes have been described. Fibrous tissue fixation, often from adhesive chronic otitis media. Tympanosclerosis, hyalinization of collagen. And new bone formation, fibro-osseous sclerosis. Fibrous tissue fixation results in a dense network of circumscribed or generalized fibrotic bands. Whoa, 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 whoa. Fibrous tissue fixation. Let's see over here. Okay. Let's see. Post-inflammatory ossicular fixation. Got it. Fibrous tissue fixation, often from adhesive, we said, chronic otitis media. Fibrous tissue fixation. Fibrous tissue fixation results in a dense network of circumscribed or generalized fibrotic bands. Fibrous tissue fixation results in a dense network. Again, fibrous tissue fixation results in a dense network of circumscribed or generalized fibrotic bands within the tympanic cavity with a proper density for the overwindow nick, resulting in a stapedial fixation. Typically, patients present with a disproportionate conductive deficiency relative to imaging findings of middle ear debris, which should suggest fibrous fixation. Whoa, 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 whoa. a disproportionate conductive efficiency relative to imaging findings of middle ear debris, which should suggest fibrous fixation. On imaging, non-calcified fibrous tissue is seen on imaging. Non-calcified fibrous tissue is seen encasing portions. Again, on imaging, non-calcified fibrous tissue is seen encasing portions or all of the ossicular chain. Non-calcified fibrous tissue. Differentiation from underlying cholesteatoma is challenging. However, cholesteatoma is more frequently associated with ossicular chain and tympanic wall erosion. A history of chronic otitis media in the setting of a dry middle ear should alert the clinician to ossicular fixation. So it is again caused by chronic otitis media, usually, most commonly. CT appearance of tympanic sclerosis is often subtle, and a working knowledge of normal anatomy is crucial in determining its extent. Calcium deposition commonly involves the suspensory ligaments and tendons within the tympanic cavity. Calcium deposition commonly involves the suspensory ligaments and tendons within the tympanic cavity. Involvement of the annular ligament of the over window. Annular ligament of the over window is the foot of the stapes. Okay. Calcium deposition commonly involves the suspensory ligament and tendons within the tympanic cavity. What is the suspensory ligament? So what are the suspensory ligaments? Based on branded sensory ligaments are anatomical structure located within the tympanic cavity. The text note in case of tympanic ligaments, more general suspensory ligament is the type of ligament that supports an organ structure. It's not a disclaimer. Okay, I have no idea what he means by that. Okay. Let's do like this. Let's see suspensory ligaments of the middle ear. The suspensory ligaments of the middle are delicate fibrous structure that helps stabilize the ossicles within the middle ear round. Malleus suspensory ligament, anterior ligament of malleus, lateral ligament of malleus, superior ligament of malleus. Incus ligament, superior ligament of incus, and posterior ligament of incus. Stapes suspensory ligaments, annular ligament of stapes. Function, support, mobility, control, protection. Okay, that is it. Calcium deposition commonly involves the suspensory ligaments and tendons within the tympanic cavity. Involvement of the annular ligament of the window may result in stapes fixation. Involvement, okay. Tympanosclerosis of the tympanic membrane should be obvious clinically, but appears thickening and increased density of imaging. But what causes tympanic sclerosis? What causes tympanic sclerosis of the middle ear? Transcranial middle ear is a pathologic cause characterized by calcification, ionization of the tympanic membrane and middle ear mucosa, often forming plaques. The underlying cause is chronic inflammation of the middle ear. Chronic or recurrent otitis media is the most common precipitating factor. Persistent inflammation leads to fibroblast proliferation and deposition of collagen in the lamina propria of the tympanic membrane and middle ear. Over time, calcium phosphate crystals deposit in the fibrous tissue, forming sclerotic plaques. Predisposing factor, recurrent acute otitis media or chronic otitis media with effusion. Myringotomy or tympanostomy tubes. Trauma from tubes or surgical intervention can promote inflammation and scarring. Eustachian tube dysfunction leads to negative middle ear pressure. fluid accumulation, and chronic irritation. Age, more common in adults, and inflammation, some individual. Inflammatory mediators stimulate fibroblast activity, collagen-rich tissue undergoes utilization, degeneration into a glassy cellular state. Calcium phosphide is deposited in these areas, forming visible white plaques. Can involve tympanic membrane alone or extend to the circular chain, potentially causing conductive hearing loss. Often asymptomatic if confined to the tympanic membrane, may cause conductive hearing loss if hospitals are involved, frequently discovered incidentally on endoscopy or imaging. Tympanosclerosis of the tympanic membrane should be obvious as thickening and increased density on imaging. Fibrous osseous sclerosis is the least common type of pro-inflammatory circular fixation and appears as new ectopic lamellar bone from deposits osteoblasts and frequently involves the epitympany. Long process of the incus deficiency. Long process of the incus deficiency. With improvement of CT imaging, long process of the incus deficiency. What do we see right over here? We see, okay, very hard to see, I must say. With improvement of CT imaging, deficiency of the lung process of the incus is more frequently recognized. It is more prone to injury given its tenuous blood supply and is susceptible to erosion from inflammatory conditions such as chronic otitis media and cholestatic. An air gap is visualized on imaging. Hold on. Wait a second. With the move of CT imaging, deficiency of the lung process of the incus is more frequently recognized. It is more prone to injury given its tenuous blood supply and is susceptible to erosion from inflammatory conditions such as chronic otitis media and cholestatic. An air gap is visualized on imaging at the incustapedial joint and is best appreciated on coronal and postural imaging. What do we see here? Tympanosclerosis. Okay. Axial CT images of the right temporal bone demonstrate amorphous calcification. Arrows in A. Amorphous calcification in the epitympanum around the ossicles, as well as calcification of the tympanic membrane. Arrow B. Calcification of the tympanic membrane. What are you saying? What are you saying? Okay. Ossicular dislocation. Please see previous section on temporal bone trauma for further discussion. Ossicular dislocation. Okay. Inner ear. Third window phenomena. Third window phenomena occurs in the presence of a structural defect of the inner ear bony framework. Potential defects include dehiscence of the semicircular canals, enlargement of the opening of the vestibular aqueduct, dehiscence of the scalar vestibule, side of the cochlea, and bony thinning between the cochlea and adjacent vascular channels. Superior semicircular canal dehiscence is the loss of bony covering of the superior semicircular canal, most often at the arcuate eminence. Dehiscence is reported in up to 12.6% of patients and 0.5 to 0.6 post-mortem studies. High-resolution CT would demonstrate a focal osseous defect along the roof of the superior semicircular canal, which is in continuity with the floor of the middle cranial fossa. This is best evaluated on postural and Stanver's views. High-resolution T2 weighted MR imaging with CIS or Fiesta has a high negative predictive value, though it prone to false positive. Right. High-resolution CT will demonstrate a focal osseous defect on the roof of the superior semicircular canal, which is in continuity with the floor of the middle cranial fossa. This is best evaluated portion of the view. Got it. Now, high-resolution T2 weighted MR imaging with CIS or Fiesta has a high negative predictive value, though it is prone to false positive. What do you see on MRI T2 on superior semicircular canal? What do you see on MRI on heavy T2 sequences like CIS or Fiesta on superior semicircular canal dehiscence? So, on heavy T2-weighted sequences like CIS, which is short for constructive interference in steady state, or Fiesta, which is fast imaging employing steady state acquisition, which are excellent for high resolution imaging of fluid structure, superficial canal typically plays from loss of bone roof. Normally, the canal is surrounded by thin hypointense line representing bone. In superficial circular canal dehiscence, this hypotenuse line is interrupted or absent, creating a direct communication between membranous canal and cranial cavity. Let's see. Superficial circular canal dehiscence on Fiesta 5. Let's see some imaging. What are you talking about? Let's show this. Open image in new tab. Wow, it's very small. I don't see anything. What? You're lying to me. You're just lying to me, Penny. No, man, I want to see this on MRI. No, man, you can't say that. No. High resolution T2 weighted MR imaging with CIS or Fiesta has a high negative predictive value, though it is prone to false positives. Posterior semicircular canal dehiscence is relatively uncommon, but can occur either sporadically or in the presence of superior canal dehiscence. Posterior semicircular canal dehiscence is relatively uncommon, but can occur either sporadically or in the presence of superior canal dehiscence. Okay. Superior semicircular canal dehiscence, portion and stem of CT images obtained parallel and perpendicular to the superior semicircular canal, respectively, demonstrate a focal osseous defect along the roof of the superior semicircular canal. Autosclerosis, autospondiosis. Okay, so we're finished with this, and we're going to sensory neural hearing loss and imaging. This is not impulsive tinnitus after this. Let's see what else. Oh my god. This is very long. Okay. So we have about posterior tinnitus, we have about sensory neural hearing loss, and we're now on, here it is. Not far away. Not far away. Right. So autosclerosis, autospondiosis. Autosclerosis is a temporal bone dyscrasia. What's dyscrasia? What is dyscrasia? Medicine dyscrasia refers to an abnormal pathological condition of the blood or bone marrow, often involving the imbalance of several components of elements. What the connection? Pathological blood or bone marrow? How it is related to autosclerosis? Autosclerosis is a temporal bone dyscrasia that was genetic. So how? So how? So how? Autosclerosis is temporal bone dyscrasia. Also, sometimes described as temporal bone dyscrasia, and this is to linked back to the classical dyscrasia, abnormal tissue competition, or metabolism. Autosclerosis is localized abnormal bone remodeling. of the audit capsule. Dyscrasia in the context refer to abnormal bone metabolism, abnormal bone matrix composition. Okay, let's click harder. So how autosclerosis is temporal bone dyscrasia? Let's see what he gives me now. Because autosclerosis is a localized disorder of bone remodeling with the OT capsule, i.e. a focal metabolic structure abnormality of the temporal bone, is accurately described as temporal bone dyscrasia, a bad mixture of abnormal tissue state of bone dyscrasia. In ENT, the phrase temporal bone dyscrasia is used exclusively to mean a local abnormality of the bone's normal structure or metabolism. Autosclerosis is not a systemic bone disease, but a focal dysregulation of bone remodeling confined to the OT capsule part of the temporal bone, so the term fits. Normal and chondral bone of the OD capsule is replaced by abnormal vascular woven spongiotic bone in active lesions, photospongiosis, and later by dense sclerotic bone in active lesions. The active phase shows osteoclastic resorption with vascular proliferation and immature bone formation. The inactive phase shows sclerosis and loss of vascularity. Typical location and clinical costume, most common site, fistula antefenestrum anterior to the oval window, progressive fixation of the stapes foot plate, conductive hearing loss. If disease extends to the cochlear capsule, cochlear otosclerosis, it can damage the organ of cortis, spiral ligament, or alter unique vascular environment, sensory neural hearing loss, or mixed loss. What is cardia rather than simply sclerosis? The word with the sclerosis names the eventual sclerotic phase, but the disease process involving any abnormal osteoblastic activity, osteochondrosis. A dysregulated remodeling process, calling it a dyscrasia, highlights the abnormal metabolic remodeling activity localized in the temporal bone, not just the end stage sclerosis. Strong genetic component, usually autosomal dominant with variable penetrates, viral measles, and hormonal factors worse during pregnancy have been implicated. Local immune inflammatory factors may play a role. This diverse influences produce the abnormal bone remodeling, the dyscrasia, how it is recognized, the geometric conductive hearing loss with Carhart notch, type 8 tympanogram, usually AS, absence abnormal acoustic reflex, city temporal bone, hypodense lucent foci in active otospongiotic areas around over window and the fenestra region, sclerosis in chronic lesions. Histology, replacement of normal and chondral or the capsule bone with vascular spongy bone later maturing to dense bone. Therapeutic implication, conductive components, stapedectomy, mechanical correction, or cochlear involvement, hearing aids, and in some cases, medical therapy, fluoride or bisphosphonate in slowing active bone turnover, evidence mixed, used mainly for progressive sensory neural component. Bottom line, can cochlear implant be used for a case where autosclerosis invaded the cochlea? Okay. Yes, cochlear implant can be used in patients with cochlear autosclerosis, but there are important considerations because disease can complicate surgery and outcomes. Sensory and hearing loss and cochlear involvement, usually in cases where conventional hearing is not effective, challenges, cochlear ossification fibrosis, osteoporosis can lead to sclerosis in cochlear nerves, sometimes causing partial or complete obstruction of the scarlet tympani. This can make electrode insertion more difficult and sometimes requires special technique, drilling throughout the passer 10, double array electrodes, or short electrodes. Abnormal anatomy, the sclerosis often thins or remodels the OD capsule, potentially making cholesterol. Cochleostomy more challenging. There is a small risk of perilymphatic closure if the endosome is thin, although this is much less common than in congenital malformation. Dense sclerotic bone may increase insertion trauma and sometimes affect initial electrode impedance. Post-operative mapping may need adjustment to accommodate depth changes. let's say that תהיה חזק, נחמד לשמוע שהתחלת, כדי שתכתוב. Surgical consideration, electro choice, insertion technique, round window approach, if possible, colics. Okay. Okay. Autosclerosis is in temporal bone dyscrasia with bone genetic and environmental causes. It is characterized initially by resorption of the lamellar bone, the otic capsule, followed by replacement with a new spongy and vascular bone, usually in greater volume than the original bone. Over time, this vascular bone gradually becomes densely calcified. Autosclerosis is classified as fenestral or retrofenestral, depending on the site of involvement. However, it likely exists on both on a continuum. Fenestral autosclerosis refers to involvement of the fistula antefenestrum anteromedial to the oval window. This notch represents an embryonic remnant of cartilage and connective tissue between the oval window and cochleariform process, where the tensor tympani tendon turns laterally toward the malleus. The cochlear promontory round window niche and facial nerve canal may also be involved. Wait, so we said that fenestral is referred to involvement of the fistula antefenestrum. Let's take the fistula antefenestrum. Fistula antefenestrum, footplate, vestibule, stapes. Fistula antefenestrum. What is it? Fistula antefenestrum. I don't know, some protrusion of bone, I think. I don't know what is it. It should be anterior medially to the oval window. It looks no. Yes, anterior medially to the oval window. That's right. That's quite right. Anterior medially to the oval window. This notch represents an embryonic remnant of cartilage and connective tissue between the oval window and cochleariform process where the tensor tympani tendon turns laterally toward the malleus. The cochlear promontory, round window niche, and facial nerve canal may also be involved. The, what did it say? Here it is. Let's close this down. The cochlear promontory, round window, and facial nerve canal may also be involved. On CT, fenestral autosclerosis is noted as demineralization anteromedial to the oval window. On CT, fenestral autosclerosis is noted as demineralization anteromedial to the oval window. On CT, fenestral autosclerosis is noted as demineralization anteromedial to the oval window. Let's see autosclerosis. Let's see, okay. Let's see what we've got here. So we really see some hypoattenuating area anteromedially to the oval window. That's right. Let's see right over here, maybe. Let's try to open this up. Open image in a new tab. Let's see. Now, here it is. This is the oval window anteromedially. It's here. Not really seen. I don't know. I don't really see right over here. Here it is. Let's look on it on a bigger image. And here is the oval window. So anteromedial, you see some hypoattenuating area or this. Okay, demineralization after mediated overwinter. New bone deposition here impinges on the stapes foot plate, leading to fixation and resulting in chronic in conductive hearing loss. This progression is characterized by increasing extent of lucencies. Wow, wow. In CT, fenestrial otosclerosis is noted as demineralization anteromedial to the oral window. New bone deposition here impinges on the stapes foot plate, disease progression is characterized by increasing extent of lucency, which can obliterate the ovoid. On CT, fenestral otosclerosis is noted as demineralization anteromedial to the overwindow. On CT, fenestral otosclerosis is noted as demineralization anteromedial to the overwindow. New bone deposition here impinged on the stapes foot leading to fixation and resulting in conductive hearing loss. Disease progression is characterized by increasing extent of window. 2% of all cases, referred to as obliterative otosclerosis, and important to note given that the presence of which requires surgical drilling prior to the implantation of stapes prosthesis. Other important landmarks to evaluate include the round window niche. Involvement of the round window increases the failure rate of stapes surgery. So otosclerosis, autospondylosis. Axial and coronal CT images of the right temporal bone in patients with fenestral otosclerosis demonstrate lucency in the otic capsule. Lucency in the otic capsule. The visual antifenestral anteromedial. Axial and coronal CT images of the right temporal bone. Oh my god, no, no. So someone shows me some commands on CMD. That's fine, but let's continue. Okay, so what can we see? We see what the hell? Okay, otosclerosis, axial and coronal CT images of the right temporal bone in the patient with fenestrial otosclerosis demonstrate lucency in the otic capsule at the fistula antefenestrum anteromedial to the over window arrows. Where do they see the over window? Okay. Axial and coronal CT. Oh, I didn't look on the right images. Oh, here I can see the over window much clearer. Much clearer. What actually of the left temporal bone in different patients with retrofenestrial sclerosis show lucencies in the otic capsule at the fistula and the fenestrum, as well as around the cochlea. I see the images of the left temporal bone in different patients with retrofenestrial sclerosis show lucencies in the otic. See the images of the left temporal bone in a different patient with retrofenestrial otosclerosis show lucencies in the otic capsules at the fistula and the fenestrum, as well as around the cochlea. Uh, CT images of the left temporal bone in a different patient with retrofenestrial sclerosis show lucency in the otic capsule at the fistula and the fenestrum, as well as around the cochlea. Okay. Okay. Retrofenestral otosclerosis rarely occurs independent of fenestral. Oh, wait. Retrofenestral otosclerosis rarely occurs independent of fenestral otosclerosis. Patients more often present with mixed hearing loss and sometimes pulsatile tinnitus. Pulsatile tinnitus. Why would otosclerosis cause pulsatile tinnitus? Otosclerosis can cause pulsatile tinnitus. If yes, why and how would it? And the answer is yes. Otosclerosis comportamental, though it's less common than more typical non-pulsatile conductive hearing loss related tinnitus. The mechanism is subtle and related to change in bone conduction and inner ear mechanism. Let's break it down. Otosclerosis is this plastic disease of the aortic capsule, mainly affecting the stapes footplate and sometimes the cochlear capsule. It becomes fixed, reducing the efficacy of mechanical sound transmission to the inner ear, conductive hearing loss. In cochlear disease, invade the cochlea, potentially causing sensorineural hearing loss. Most tinnitus is non-pulsatile, caused by altered cochlear mechanics, abnormal health service stimulation, and increased spontaneous firing at the auditory nerve due to status fixation. Though rare, occurs when the patient perceives a rhythmic sound and movement. Mechanism pulsatile consequence. Step-on conduction transmission. Otosclerosis lesion can change the impedance of cochlear bone. Blood flow pulsatiles in adjacent vessels, the artery, cochlear vessels, can transmit via abnormal bony conduction pathways, becoming perceptible as pulsatile tinnitus. So, which type of tinnitus is more common in otosclerosis? The most common type of tinnitus is non-pulsatile subjective tinnitus. Easy breakdown. Mixed hearing loss and sometimes pulsatile tinnitus. Lucent spongiform bone is deposited around the cochlear capsule with a classic four-ring of Barbasori. or continuous ring of loosened bone around the cochlea. Progression of disease involved the perilabyrinth bone. Over time, in the more chronic phase, this spondiotic bone is replaced with dense bone which may be indistinguishable from normal otic capsule on imaging. Subtle periosteal thickening may be the only indicator. Sensory neural hearing loss is thought to be the result of direct cochlear and spiral ligament injury. Subtle periosteal. This wait. Continuous ring of loosened bone around the cochlea. Progression of disease involved the perilabyrinth bone. Over time, in the more chronic phase, this spondiotic bone is replaced with dense bone, which may be indistinguishable from normal otic capsule on imaging. Subtle periosteal thickening may be the only indicator. Sensory neural hearing loss is thought to be the result of direct cochlear and spiral ligament injury secondary to pullolytic enzymes. It has been proposed that severity of cochlear disease correlates with the early onset of severity of sensory neural hearing loss. What's the time? It's 9 and a half. 9 and a half is the money almost think. I don't know. Sensory neural hearing loss. Sensory neural hearing loss indicates inner ear or retrocochlear pathology affecting the cochleovestibular nerve. Sensory neural hearing loss indicates inner ear or retrocochlear pathology affecting the cochleovestibular nerve and/or central auditory pathway. Imaging plays a key role in identifying treatable abnormalities of the structures. MRI is the imaging modality of choice in the setting of sensory neural hearing loss because it offers enhanced visualization of the fluid-filled inner ear structure, ISC, CPA, and brain. Let's see. What is this process of conversation? Still, no. Enterprise line market share. Okay, I don't see here something very interesting. Let's move on. Okay, MRI is the imaging modality of choice in the setting of sensory neural hearing loss because it offers enhanced visualization of the fluid field inner ear structure, internal auditory canal, CPA, and brain. Recent literature has questioned the utility and efficacy of contrast for screening examination. However, contrast-enhanced T1-weighted images may additionally detect abnormalities that inflammatory or central nervous system lesions not readily suspected by clinical exam. I think that vestibular schwannoma enhances with contrast on T1, and the answer is yes. Vestibular schwannoma generally show avid homogeneous contrast enhancement of T1 weighted images. Is one key diagnostic feature. Enhancement pattern, strong homogeneous enhancement with gadolinium contrast in most cases. Distinguish tumor from solid CSF from tissue makes the lesion. Pre-contact iso-intense to hypo-intense, similar slightly darker than brain. Intense, usually homogeneous, hyper-intense bright. Mutation, large tumor show heterogeneous enhancement of the cystic degeneration, hemorrhage, or necrosis. The enhancement What are the criteria to surgical intervention in student moment and what are the criteria for observation? Contrast and imaging is therefore essential for technical reasons. Large tumor more than 3 centimeters, indicating of surgery, tumor size and growth, documented tumor growth on serial imaging more than 2 millimeters per year, tumor causing brainstem compression or hydrocephalus, symptomatic evolution, progressive hearing loss, especially if useful hearing remains and might be preserved, intractable vertigo or balance problem affecting quality of life, facial nerve symptoms, trigeminal neuralgia or facial numbness, patient factor, younger age, patient preference, good surgical candidates, specific clinical scenarios, tumors only hearing ear, tumor only inner ear, cystic tumor may grow unpredictably. Surgical approach depend on tumor size, hearing status, surgical observation, ideal intracanalicular or small CPA tumors, no growth on serial imaging, about 50 to 70% of small tumors show minimal no growth, asymptomatic or minimal symptomatic mild hearing loss that is stable, no balance issue or well compensated vestibular symptoms, no article now, patient elderly, significant medical disabilities, only hearing ear with serviceable hearing, bilateral tumors, observation protocol, MRI 6 months and annually for 3 to 5 years. Long-term follow-up stable can extend to 2 to 3 years. Asymmetric animal, regular symptom evaluation, alternative treatments. Stereotactic surgery, indication for surgery, small medical contraindicated surgery, patient preference, growing tumors, procedural tumor control in 90 to 95%, 5 to 10 years, key decision factors, tumor characteristics, size, symptoms, severity, hearing status, modern trend, increasing use of observation for small asymptomatic tumors with intervention reserved for documented growth or symptomatic progression. So cutoff is about 2 centimeters, 3 centimeters. Okay. Sensory indicates inner ear or retrocochlear pathology affecting the cochlear-vestibular nerve and or central auditory pathway. Imaging plays a key role in identifying treatable abnormalities of the structures. MRI is the imaging modality of choice if in the setting of sensory neural hearing loss because it offers enhanced visualization, of the fluid-filled inner ear structures, internal auditory canals, CPA, and brain. Recent literature has questioned the utility and efficacy of contrast for screening optimization. However, contrast-enhanced T1-weighted images may additionally detect abnormalities such as inflammation or central nervous system lesions not readily suspected by clinical exam. Recent literature has questioned the utility and efficacy of contrast for screening examination. However, contrast-enhanced T1-weighted images may additionally detect abnormalities such as inflammation or central nervous system lesions not readily suspected by clinical exam. Inflammation, central nervous system lesions. CT may offer complementary information for surgical planning, in particular for localization of facial nerve canal. CT may also add diagnostic value by providing improved osseous detail of the body capsule and labyrinth, demonstrated inner mineralization in labyrinthine ossificans and otic capsule retencies in osteoporosis otosclerosis. Pathology. Vestibular schwannomas. Vestibular schwannomas are the most common pathology encountered on MRI examination performed for sensorineural hearing loss and over the most common CPA and IAC neoplasm. So wait, can I ask you which is more common? Vestibular schwannoma or cholesterol or granuloma in the inner ear and CPA. So the answer is vestibular schwannoma is significantly more common than cholesterol granuloma in both the inner ear and the 7-point angle. It's the most common tumor of CPA, accounting for approximately 80 to 90% of all CPA masses. It arises from the Schwann cells of the vestibular portion of the 8th cranial nerve. The incidence is roughly 1 to 2 per 1,000 people per year. In the CPA specifically of the vestibular schwannoma, the next most common lesions are angiomas and epidermoid cysts. Carcinoma would be considered quite rare in this differential. Vestibular schwannoma is far more common in both locations, particularly in CPA where it's dominant pathology. Thank you for you. Thank you all. Now let's continue with this one. So, vestibular schwannoma are the most common pathology encountered in MR examination performed for sensorineural hearing loss and overall the most common CPA and IC neoplasm. Okay. That's where circumscribed lesions typically involve the eighth cranial nerve and are typically T1 is intense, T2 hyperintense, and homogeneously enhancing on MRI. However, varying composition of Antoni A and Antoni B cells may render a lesion more cystic with less homogeneous contrast enhancement. What are Antoni A and Antoni B cells? What are they related to the steroid form? The answer is Antoni and Antoni are histological patterns seen in schwannomas, which are benign nerve-sheath tumor. They are named after pathologies Antoni A. Highly cellular areas with compact spindle cells. Cells arranged in organized fashion. Often shows verroque bodies. Distinguish plisade in arrangement where cell nuclei line up in parallel rows with intervening cell lysomes. More structures appearance under the microscope. Antoni B pattern. Loosely arranged cells in myxoid background. Less cellular and less organized. More hyposacral with tissue organized architecture. Contains mycocyst and evidence of tissue degeneration. Yet they are directly related. Vestibular schwannoma, so-called acoustic neuromas, are schwannoma that arise in the vestibular portion of the cranial nerve, vestibulocochlear nerve. Like other schwannoma, they typically show a mixture of Antoni A and Antoni B pattern histological examination. Most schwannoma contain both patterns in varying proportions, though Antoni A areas tend to be more prominent. Antoni B areas are thought to represent degenerative changes that occur as the tumor grows. So, cystic changes that occur in vestibular schwannomas are related to Antoni B cells. Yes, specific changes in vestibular schwannoma are indeed associated with Antoni B areas. Why Antoni B areas become cystic? Antoni B region represent area of tissue degeneration within schwannoma, characterized by loose myxoid matrix. The tissue has a mucoid keratinous quality, microcystic formation, small cystic spaces develop within the tissue, hypocellularity, fewer cells, and more extracellular fluid. Poor vascularity, inadequate blood supply leads to tissue breakdown. Fewer cells and more extracellular fluid. Small cystic spaces. As vestibular schwannoma grow larger, they may outgrow their blood supply, leading to more extensive Antoni B changes. The Antoni B areas can coalesce into macroscopic cysts. Larger tumors tend to have more cystic components. Physical vestibular schwannoma, those with significant cystic component, can be more challenging surgically because they may be larger in presentation. The cyst portion can make the tumor boundaries less distinct. Some studies suggest they may have different growth characteristics. So when radiologists or nurses describe a vestibular schwannoma as cystic or having cystic degeneration, they're essentially describing the macroscopic manifestation of extensive Anthony B change within the tumor. So let's continue. May render a lesion more cystic with less homogeneous contours enhancement, brain composition. Signal characteristics are important for prognostication, with more cystic schwannomas prone to rapid growth. Signal characteristics are important for prognostication with more cystic schwannomas prone to rapid growth. Increased hearing loss. Signal characteristics are important for prognostication with more cystic schwannomas prone to rapid growth, increased hearing loss, and poor surgical response to cholestatic surgery. Signal characteristics are important for prognostication with more cystic schwannomas prone to rapid growth, increased hearing loss, and poor surgical responses to cholestatic surgery. Lesions typically expand the internal auditory canal, and extension into the CPA classically result in an ice cream cone appearance. Still one are usually intraanalytical. Where else can they be? Does it mean something gnostically or in the face of surgical exploration? Usually intraclavicular. So Schwannoma neurogenic correctly. In fact, most are diagnosed when they have already extended beyond the intraventricular. Schwannoma can be intracanicular, confined to about cisterna, cerebral-condyle angle, most common presentation where the tumor extends into the CPA combined. Most tumors originate in the transition zone between central and peripheral myelin, osteoid zone within the internal canal, then grow outward into CPA and at large. Thus, better hearing preservation rates, often removal of some surgery, easier surgical access, lower mobility, extended surgical cabinet, and high control rates. Generally discovered earlier when so higher surgical capacity, lower hearing visitation, higher facial nerve injury, longer period of time. Stage procedure can cause brainstem compression in the cephalus. So all the schwannomas starts as intraclavicular, extends to the CPA. Not necessarily, once most vestibular schwannoma do originate within the clavicular and the Obersteiner Redlich zone where the vestibular nerve transition from central to peripheral myelin, the exact growth pattern can vary. Yes, the majority follow the sequence, start intraclavicular, go slowly over month or 2 years, extend toward the porus acousticus, open into IC into the CPA, continuous enlargement in the CPA with more space, but there are exceptions. Purely intracranial tumors can remain confined to the IC. Some are caught early for MS screening and incidental finding. Some may go very slowly or not at all. The subset may genuinely have limited growth potential. Primary seeing occasion, rarely tumors may arise from the vestibular nerve portion that's already in the CPA. Some debate exists whether all large CPA tumors necessarily pass throughout an interclinical phase or if some originate more likely laterally. Atypical growth can be asymmetrical, extending more in a direction. Some tumors have a component that can cause rapid expansion. By the time most vestibular schwannoma are diagnosed, they have already extended into the CPA. Purely intracranial tumors are typically found in the incidental MRI for other reasons. Throughout screening, doing workup for early hearing loss or tinnitus. So while intracranial CPA progression is typical trajectory, not every tumor follow this exact path, and many small intracranial tumors may win several phase, but also intracranial vestibular schwannoma can cause symptoms like loss and tinnitus. Yes, absolutely. Yes, intracranial gravity are commonly cause symptoms despite their small size and confined location. Hearing loss in presentissimos, typically urinary progressive, can be sudden cases, occur because of tumor compressed the cochlear nerve or compromises its blood supply within the tight confines of the nucleus. Very common, often accompanies hearing loss, maybe the first or only symptom in some patients. Imbalance is even or less commonly through vertigo. Deaths can occur even with small tumors. When small tumors cause symptoms, the internal body is confined body space, and small tumor can direct compress the cranial nerve, but also seven compensate vascular supply to the nerve, cause inflammation and edema. Any recurrences of neural loss, tinnitus, or vestibular symptoms should prompt consideration of MRI, with contrast to rule out vestibular schwannoma, even if symptoms seem mild. Many intracanonical tumors are caused this way before they extend into CPA. Lesion typically extends the IC, recognized measured in the CPA, classically resulting in an eye-screen appearance. Additionally, imaging considerations include abnormal intralabyrinthine signal, as well as the presence of normal CSF signal and the presence of the IAC. Increased cochlear flare signal is thought to be secondary to increased protein within the perilymph. Wet. Additional imaging consideration include abnormal intralabyrinthine signal, as well as the presence of normal CSF signal in the fundus of the internal auditory canal. Increased cochlear flare signal is thought to be secondary to increased protein within the perilymph, possibly a result of cochlear nerve compression. Initially, thought to correlate with worse hearing outcomes, this increased flare signal has been shown in more recent small prosthetic studies to have no correlation with hearing outcomes. Absent fluid signal and the fundus has traditionally been associated with poor post-surgical hearing outcomes. Absent fluid signal and the fundus has traditionally been associated with poor post-surgical hearing outcomes. However, absent fluid signal and the fundus. What's the fundus? I want to detail. Internal auditory canal. Fundus. איזה פונדוס הוא מדבר? Open new. facial canal, supervestibular nerve, infravestibular nerve, cochlear nerve. יותר. טוב, לא יודע, בקרסט פילה כבר, פיליס בר, מוזן קרסט, פורם סימילרי, ניתן קוטיסמיאנוס. אז מה אתה מדבר? איזה פונדוס? על מה אתה מדבר? The fundus of the internal auditory canal. The fundus of the lateral medial end of the internal auditory canal, which is the bony canal interval bone that connect the inner canal. It's a cribriform plate. This okay. So we have intermedius, this bar. Okay, so let's continue. Absent fluid signal at the fundus has traditionally been associated with poor post-surgical hearing outcomes. However, again, more recent literature says there's no correlation. Growth rates are variable, with 4 to 22% of lesions demonstrating spontaneous regression. Many smaller lesions can be followed annually with routine MRI imaging to assess postability. What vestibular traumas can spontaneously regress with time? Yes, spontaneous regression of vestibular trauma can occur, but it's rarely reported in about 1 to 3% of cases in regression study. What we know about regression, well documented in the literature with serial imaging, true volumetric decrease, not just measurement, can occur in both sporadic and NF2 associated tumors. Intratumoral hemorrhage, necrosis, thrombosis of feeding vessels, immune-mediated response, changing tumor biology. of the mechanism are clear, more commonly reported in older patients, sometimes follow a period of initial growth, can be partial regression or complete disappearance, very rare, may be preceded by changes in symptoms. Clinical implication, this is one reason why observation with serial MRI, where the scan is a valid management strategy for small tumors, elderly patients with minimal symptoms, those with poor surgical candidate. Most tumor, however, remain stable, 30 to 50%, grow slowly over time, 40 to 50%, only small minority regress, 1 to 3%. Important caveat, pseudo-regression can occur, TC component may fluctuate, post-contrast enhancement may vary, measurement technique can differ. So gene regression should be confirmed with careful volumetric analysis of a multiple scan, not just single measurement. The rate of regression means it shouldn't be counted on, but it will support the rationale for conservative management in selected cases. It means they were 30 to 550, 40 to 50, and grow slowly over time. Growth rates are variable, with 4 to 22% of lesions demonstrating spontaneous regression. Many smaller lesions can be followed annually with the routine MRI imaging to assess for stability. Vestibular schwannoma axial precontrast T1, post-contrast T1, and flare MR images demonstrate a well-defined enhancing mass, solid arrows, expanding the right internal auditory canal and extending into the CPA. Increased flare signal is demonstrated. Increased flare signal demonstrated in the cochlea, dashed arrow, really, so to reflect increased protein within the perilymph. This is quite hard to see, yeah? So let's see right now. Meningioma. Meningiomas are the second most common lesion in the CPA. Cistern. What is the meaning of cistern? What is the meaning of what is the meaning of cistern? Like in medical context, cistern refers to several spinal fluid space in the brain. The CPA cistern, the small cistern, is CSF filled space located in the angle between the cerebrum and the pons. It's one of the several enlarged subarachnoid spaces around the brain where cerebrospinal fluid naturally collects. It is always hard and enlarged subarachnoid space. Good question, not always. Those are closely related concepts. Most cisterns are in lots of our spaces. These are the major named cistern like Poitin cistern, supercellular cistern, quadrigeminal cistern, and cisterna magna. This form naturally subarachnoid space. However, cistern in anatomy can also affect cistern within space. In subarachnoid companion, even smaller ones, terms sometimes used more loosely to describe cistern spaces that may not be dramatically large. Let's see, just okay. So while the classes named cisterns are indeed in large subspace spaces, the term can be applied somewhat broadly to describe CSF-filled region in the subarachnoid space. The key feature is the CSF-filled space between the arachnoid and the PMR, or just subarachnoid space, whether dramatically enlarged or just recognized as the region. In practice, when neurologists refer to cistern, they're almost always talking about the well-known enlarged subarachnoid space that serves anatomical landmarks and may be difficult. Meningiomas are the second most common lesion with CPA cistern and may be difficult to discern from schwannomas. Key imaging features that may suggest meningioma include a broad-based dural enhancement attachment and eccentric location relative to the porus acousticus and dural enhancement and eccentric location relative to pars acousticus, relatively rare involvement of the internal auditory canal, as well as the presence of a dual tail, though this sign is not exclusive to meningioma. Additionally, schwannomas tend to expand the internal auditory canal, whereas meningiomas do not. Ultimately, diagnosis may depend on surgical pathology. Meningioma, axial pre-contrast and post-contrast. T1 weighted MR images demonstrate a well-circumscribed, avidly enhancing mass, solid arrows, primarily centered along the left tetrus ridge with prominent dual tail dashed arrows. This lesion partially extends into the pars acousticus but does not result in widening. Note also the extent location of the CPA component relative to the pars acousticus meningioma. Dual tail, of course. Ultimately, diagnosis may depend on surgical pathology. Epidermoid cyst. Epidermoid cysts are the third most common CPA lesion, cistern lesion. Less extraaxial lesions follow CSF signal on T1 and T2 weighted imaging and do not enhance. However, because of internal debris, the epidermoid cysts receive diffusion on DWI and demonstrate increased signal intent relative to CSF on FLAIR imaging. As opposed to epidermoid cysts, arachnoid cysts follow CSF on all sequences and do not demonstrate signal diffusion. Okay, so we see here in epidermoid cyst, axial postonsum T1, T2, and DWI. MR images show a non-enhancing left CPA mass that follows CSF. MR images show a non-enhancing left CPA mass that follows CSF on T1 and T2 with diffusion restriction error. Endolymphatic sac tumor, intralabyrinthine hemorrhage. Okay, so great. Okay, so we ended on epidermoid cyst. What's the time now? It's 10 o'clock. It's just here. Okay. Let's end this.